Hi, everybody. My name is Dr. Marcie Press, and I'm an interventional cardiologist here at UCLA Medical Center. I'm really excited to be here and talk to you about mitral valve disease. Specifically, I'm going to be talking about mitral regurgitation, which is a very, very common cause of valve disease, and in the context of what we call percutaneous repair. Percutaneous repair means the ways of treating valves without doing open heart surgery. And as an interventional cardiologist, it's what I am interested in and what I specialize in. Again, I'm here at UCLA, an interventional cardiologist. I'm co-director of the Women's Heart Program here, and a member of the MitraClip Heart team here at UCLA. And if you have any questions about what I'm talking about today, please go ahead and feel free to use Twitter, hashtag UCLAMDChat, or use Facebook comments to ask any questions that you have during this webinar, and at the end, we'll try to answer as many as we can. I have no disclosures today. The company that I'm going to be talking about is Abbott, MitraClip, and myself. No disclosures or financial conflicts of interest during this talk. This talk is not sponsored either by any industry. So the outline of my talk today is really, again, focusing on the mitral valve and the regurgitation that can occur during when we have issues with our mitral valve. I'll be starting talking about the anatomy of the mitral valve and specifically how common mitral valve disease is. I'll talk a little bit about why we get mitral valve disease, what are the causes of mitral valve disease, and I'll be talking about when to act. When should we do something about mitral valve disease? When should you ask your physician about your mitral valve, and when should your physician refer you to a specialist who specializes in mitral valve disease? I have to talk about mitral valve surgery because everything we know about the percutaneous repair of the mitral valve is based on the brilliant history of our surgeons, our cardiac surgeons. And since the mid-20th century, we've really, the surgeons have developed phenomenal ways of treating mitral valve disease, and that's why mitral valve surgery is still the gold standard for treatment of mitral valve disease. But now, as we enter into the 21st century, we really are in a new era, and many of the diseases that we initially thought could only be repaired surgically can now be repaired percutaneously or less non-invasively. And this the MitraClip is the first and only FDA-approved device for this indication. So I'll be talking about MitraClip. I'll be talking about the indications for MitraClip, the procedural technique, and the outcomes. In the context of this talk, I'll be introducing a case example to show you, an example of MitraClip in action, and that's what I will start with here. So this is an example of a typical patient who may be elderly, 85-year-old woman who presents to her physician with several weeks of progressive shortness of breath that started about 6 months ago. She came to an outside hospital and she was actually diagnosed with heart failure and kidney failure. She had an ultrasound or an echocardiogram of her heart that showed that she had what's called severe mitral regurgitation. And this was due to mitral valve prolapse. She had known that she had mitral valve prolapse for much of her life, but she didn't realize that it could be a problem, nor was it diagnosed until she reached the age of 85, and at that point she became what we call symptomatic. So appropriately, she was evaluated for surgery because she had a problem with her mitral valve that required surgery. But because of her age and because she was thought to be too frail and because she had heart failure and kidney failure, her surgical risk is what we call prohibitive or very high. And it really is this specific patient that really fits the perfect textbook for us as interventional cardiologists to approach and to offer the MitraClip procedure for patients who are symptomatic, who have severe regurgitation, and who are at high procedural surgical risk. And I'll repeat this over and over through the talk, but it really is the typical patient that we're talking about today. She was transferred to UCLA Medical Center at Ronald Reagan for a higher level of care and specifically for MitraClip. So let's back up a moment and talk about what is the mitral valve? Where is it? Okay, so it's one of 4 valves in the heart. And what it does is it regulates blood flow from the upper chamber to the lower chamber of the heart on the left side. So it regulates flow from the left atrium to the left ventricle. As you can see on the top of the screen, from the left atrium to the left ventricle, here's the left atrium and here's the left ventricle, and the mitral valve is in between. And the mitral valve has two flaps or leaflets, and they open when the blood goes forward, and they close when the heart contracts. And what the closing does is it prevents blood from going backwards into the left atrium. The heart is a pump, and its goal is to only pump blood forward. We do not want blood to go backwards. This really affects the efficiency of our heart and makes us feel bad when we don't have good forward pump flow. So when we have regurgitation, what happens is that the leaflets, instead of coming together nice and tightly, they actually don't close all together, or one or two of the leaflets go backwards and they prolapse. And that's one of the most common causes of mitral valve disease, is called prolapse. This prolapse, or incomplete closures of the valve, causes blood to leak backwards. It's having a leaky valve. And when blood flows backwards from the left ventricle into the left atrium, that pressure gets transmitted into our lungs, and we feel short of breath. And that is why patients with mitral valve regurgitation get shortness of breath when the regurgitation is severe. Now, mitral valve regurgitation, again, it's caused by incomplete closure of the leaflets. And there are many different types of mitral regurgitation. And I'm not going to go into the details and anatomically of each type, but just to tell you that in broad terms, one type is caused by problems with the leaflet themselves or the machinery, and the second type of regurgitation is often caused by problems with the ventricle of the heart, the left ventricle. These are classified into either a primary valve problem or a secondary valve problem. Today I'm going to be focusing on only mitral valve disease where the problem, it comes from the valve itself. Okay, that's what we're going to be talking about. So this is an ultrasound of a patient's heart. And what this shows is the left ventricle and the left atrium beating. And you can see very clearly that one of these leaflets is going backwards, and that's called prolapse. When you put color, which shows the velocity of flow nicely behind me here, you'll see all this very, very bright colors swirling around into the left atrium. And what that is all the blood flow that's going back into the left atrium. And this is what we see when we see mitral valve prolapse and severe mitral regurgitation. In fact, mitral valve prolapse can eventually lead to what we call flail, where the whole leaflet, instead of just prolapsing back, detaches from the cords and flies back, and it's now become flail. So this is a case of a flail leaflet in a patient who's had mitral valve prolapse and developed severe regurgitation. So mitral regurgitation is actually the most common type of valve disease. It's twice as common as aortic valve disease. Here at UCLA, we have a very, very, very robust aortic valve program. Many patients who come see us have what's called aortic stenosis. Mitral valve disease is actually twice as common as aortic stenosis. So it's actually very important for us to recognize if we have mitral valve disease and to seek treatment. It's actually prevalent in up to 10% of the United States population, and it increases with age. In fact, most valve diseases increase with age, and this is very common for valve disease. About more than 250,000 cases of mitral valve regurgitation are diagnosed annually in the United States, and the clinical course is not always predictable. We do know, however, that if you are diagnosed with severe symptomatic regurgitation, that you may have up to a 45% one-year mortality. And so this is very high. This is one of the reasons why if you have severe symptomatic mitral regurgitation, it's very important that you see a cardiologist or a specialist in mitral valve disease. The other important point is that patients with mitral regurgitation, as they advance in their disease and become symptomatic, have a very high incidence of needing to be rehospitalized. And so their quality of life becomes significantly impacted by mitral valve disease. So in our patient, as I mentioned, mitral valve surgery has been the gold standard for mitral valve disease. And she's 85, she came to us and she had mitral valve prolapse, flail, regurgitation. She was quite sick, as I mentioned. She had heart failure and kidney failure. And when we asked a surgeon to consider operating, as a team, we decided that it would be too high risk to operate. So there's something called surgical risk assessment, and we actually have a very defined way of how we determine a patient's surgical risk. It includes age, it includes presence of heart failure, presence of coronary artery disease, presence of kidney problems, lung problems, history of stroke, and prior surgeries. There's actually a calculator we use called the STS score, where we can calculate the estimated risk of mortality if you were to go through surgery. And in this patient, as an example, she would have had a 35% chance of not surviving a surgery should a surgeon have decided to operate on her. So we take surgical repair out of the question for her. She's too sick to have surgery. So what else can we do for her? There are two options. One is medication alone, and the second is now percutaneous repair with MitraClip, which has really, I think, changed the landscape significantly and really offered a significant benefit to many, many patients out there who are not surgical candidates and really now have an option for fixing the valve without open heart surgery and the use of MitraClip. It turns out for the type of, for patients that have prolapse or flail, medications help in symptoms, but they don't alter the course of the disease, meaning that if you have a problem with the valve usually needs to be repaired. So MitraClip is a wonderful option. Like I mentioned, medical therapy doesn't change the outcome or disease progression, and it can treat symptoms. So, example, your doctor may put you on a diuretic to help reduce the amount of volume or blood flow that's going backwards, and this may help you feel better. But if you really truly have a mitral valve prolapse and severe regurgitation, no medication is going to change the final progression of the disease itself. And therefore, we do need another option. It turns out that about only 20% of patients who have mitral valve disease and severe MR actually have surgery. That means that 80% of patients don't get surgery when surgery is indicated. And about half of those patients, the reason that they're not getting surgery is because they're high risk. And these are the patients, again, for which the MitraClip really has become a game changer. So now we're going to go and talk a little bit about the surgeon's perspective. And as I said, before I get to MitraClip, it's really important for me to tell you about what surgery is, because surgery is, again, the gold standard. Mitral valve surgery actually started in 1956. The first mitral valve surgery was performed by Walter Lillehei. And it wasn't until 1960s until the first mitral valve replacement was performed. Now, there are two ways of treating a valve, so we can start surgically. One is replace the valve, and the other one is repair the valve. The first surgeries that were done on the mitral valve were done as a replacement. The technology in the 1960s was really limited for these valves, and they didn't know how to treat the valve appropriately. And what would happen to these patients is that the valve would degenerate early, meaning it would lose its function early, or it would thrombose or clot off. And this was a major problem for these first patients in the 60s who were being operated on. So Dr. Alain Carpentier, a French surgeon, really transformed the mitral valve field, and he was the first surgeon to describe a repair technique. So instead of just replacing the valve, Dr. Carpentier came up with a way to repair the valve. And it's actually his repair is the basis for what surgeons still do today. It's called the Carpentier technique, and it's the basis for mitral valve surgery today. And there are two portions that are very important to a Carpentier valve technique. One is fixing the leaflet, and the other one is putting a ring around the actual annulus of the valve. And I'll talk about that in a moment. This was a picture of the first paper that was published back in 1968 by Dr. Carpentier, the French surgeon here, and that's a picture of him. And this is his technique. He basically cuts a little portion of the leaflet out, the leaflet that's redundant or prolapsed, and he sutures the rest of the leaflet together. So now the leaflet is not going to prolapse. It will now close adequately. And he also puts a ring around the annulus to basically make the annulus more of a, makes it smaller so that the leaflets will touch. So the two parts of the surgery are resecting the leaflet, and the second is bringing the annulus together so the leaflets will touch. And this is what surgeons do today, and this is a picture of a patient's heart with a ring and a Carpentier repair. There was another surgeon after Dr. Carpentier, and his name was Dr. Alfieri. And Dr. Alfieri decided to come up with a different strategy. Instead of using Carpentier's resection and annuloplasty, Dr. Alfieri decided to do something a little bit different. And his technique is based upon what's called an edge-to-edge repair. And he would take a suture and basically grab one leaflet, then grab another leaflet and suture them together right in the middle where the leakiness occurs. And that's called the Alfieri edge-to-edge technique. And here you can see a picture of that. The leaflets here are basically sutured with the leaflet, and now that creates almost like it's called a double barrel. It looks a little bit like an owl face, I think. And that is really, had been quite successful in his hands. And some surgeons today still use his technique. The reason that I bring it up is because it's the basis for the percutaneous repair. And it's from Dr. Alfieri that the MitraClip procedure actually was born. This is an Alfieri technique, a picture of it in the operating room. As you can see, there are sutures right in the middle of the valve, and you have two holes on either side, and that's the Alfieri. And here is the MitraClip. Finally, I'll show you. And the reason I show these back to back is to show you that up on the upper right is the Alfieri edge-to-edge technique, and the MitraClip looks almost the same. And that's why I say that this procedure really is a mirror of the surgical technique that Dr. Alfieri came up with. So finally, what is MitraClip? MitraClip is a percutaneous or minimally invasive or non-invasive strategy of repairing the valve. It's not a replacement, it is a repair. And what we do with MitraClip is we deliver a catheter up here on the middle of the screen here through the vein in the leg, and we deliver this clip, which is up here. It looks almost like a stapler or a paper clip. And what this paper clip does is it attaches to the two leaflets of the valve, and it will close. And the closing of this clip brings the leaflets together just as you see, like a suture in the Alfieri. And this clip prevents the leaflets from going backwards and treats the regurgitation. And I'll show you again a schematic of this as well. So MitraClip is basically made of metal alloy. It's cobalt chromium, and it's the same material that we often use as the basis of stenting. So it's very friendly to the heart, and the heart we've had a lot of experience with the material that's used in MitraClip. There's essentially no risk of, for example, having an allergy to the clip or anything like that. It's based on cobalt chromium and polyester, which are very well tolerated and healed by the heart. As I said, this is what's often used in other coronary implants. Here is a schematic of the actual picture of the procedure in cartoon, so you can see, and I'll try to talk through what actually happens during the procedure. So this is the left ventricle and the left atrium, and that blue blood that you see going backwards is the regurgitation that we talked about. This is a picture of the device. It has a handle with some knobs that allow us to steer the device. And we bring the device up into the right atrium over a wire. We make a very small incision in the septum, which divides the right and left heart. And we deliver the catheter into the left atrium or the upper chamber of the heart. Once we have the catheter delivered there, we then introduce the clip. This procedure is done under ultrasound guidance. We can see everything we're doing by using what's called a transesophageal echo. So we can maneuver this clip in many different directions using our knobs at the back of the device. And we can see exactly where the regurgitation is coming from. And once we've identified the regurgitation, the clip arms will open and they look like they become a T conformation. And then we can rotate the clip in any direction so that we're always perpendicular to the plane of coaptation. Once we see where the clip is regurgitations and we're comfortable with our position, we introduce the clip into the left ventricle and we bring it just below the tips of the leaflets, and we let the leaflet tips rest on the clip arms and close the clip. And we can readjust this as many times as we want until we get the perfect fit. Once the clip is secure, we then release it from the delivery catheter, and this is what we end up looking again. There's that sort of owl-looking face with the double barrel mitral valve. And this basically will reduce the regurgitation significantly. And I'll talk about a little bit about what that means and how much we can reduce using this technique. We often need to use more than one clip. We can put 2 or 3 right next to each other and clip away most of the regurgitation there. The clip is secure and it stays there forever. It doesn't go anywhere. It eventually, what we call endothelializes, or tissue grows around it, and again, it will stay there. So once we're done, we can take everything out. The procedure, here's a before picture with regurgitation, and here's the after picture. So patients usually come in the morning, and the procedure takes about 2 to 3 hours. It does require general anesthesia, and most cases, patients can go home the following day. This is a huge breakthrough because it's really one of the only mitral valve or any valve procedure where you can go into the hospital with regurgitation and just one day later leave as without having any major open heart surgery, and go home the next day and have really good treatment of that regurgitation. So it's quite exciting. The timeline, we've known about this device since about 2003. So as in terms of the world experience, it's been around for many, many years. It's been around for about 14 years. However, it was only approved in 2013. So in the United States, the experience that we have with the MitraClip has been for about 4 years. The indications for use, and this is out of the actual labeling on the device, is again for patients that have severe symptomatic mitral valve regurgitation due to a problem with the valve itself, who have been determined to be at prohibitive surgical risk, to be determined by a mitral valve surgeon as part of a heart team. And I'm going to talk about the heart team in a bit. It's something that I think is extremely important, and what we have at UCLA, a really wonderful group of doctors from very varying specialties, where we all weigh in and sort of review each case in detail, talk about the risks and benefits of each approach in terms of management of these complicated patients. What is prohibitive risk? I'm not going to get into the numbers, but just to tell you, as I mentioned earlier, there is a surgical thoracic score, or an STS score, that we can use that takes into consideration many patient characteristics. And in patients who have a high surgical risk, we may determine that they are very good candidates for this therapy. This is called Everest 2, which is really the basis for the approval in the United States. It's what we call the landmark trial. And if you're out there thinking about getting MitraClip and you're really interested in knowing what's the data behind it and what do I read, how do I know if it's the right thing for me, what's the experience been, I only bring this up to let you know that this is what we call the landmark trial, and it would be one of the papers that I would recommend reading if you're really interested in getting down to the nitty-gritty about the numbers, the experience, and the outcomes. It was a randomized trial that looked at patients that were either going to get the MitraClip or surgery, and it compared the outcomes for those patients over about 5-year outcomes. And this was what we call a safety trial and an effectiveness trial. The device was proven to be safe and effective. The most interesting part about this trial and what it showed us was that despite MitraClip not being able to get rid of all of the regurgitation, the effectiveness was still significant, meaning that in this trial, patients who underwent MitraClip had about an 80% reduction in their regurgitation, and that was defined by more than 2-grade reduction. So taking you from a 10 out of 10 regurgitation to a 5 out of 10 regurgitation. That's what we consider success. I tell my patients the goal of this procedure is not to cure the disease. The goal is to basically reduce the regurgitation by more than 50%. The good news is that even in patients who had only 50% reduction, they experienced a 97% reduction in their heart failure symptoms. So that means that even though the surgical group may have had a better technical success, the surgeon can see everything they're doing, opens the heart, repairs the valve, and may be able to get a better, may be able to take you from a 10 out of 10 to a 2 out of 10. It turns out that clinically, patients with MitraClip will still achieve even potentially better symptomatic relief without undergoing the open heart surgery. So this is a sort of a little bit of a nuance from this study that I point out, and I can answer some questions about it at the end. I know that concept may be a little bit tricky. But in terms of our experience in the United States, our success rate is more than 80%. So in Everest, I said it was about an 80% success rate. In real terms, in the U.S., and this is because we've had so many years of working with this device, our success rate is about 93%. So if you have the procedure, there's a 93% chance that you will get a more than 50% reduction in the regurgitation. The complication rate is about 8%, and it's really this is pretty standard for any procedure that you may have. There's a risk of bleeding, risk of stroke, risk of embolization, very, very low, only 0.4%. So it is a relatively safe procedure, but just so you understand, every procedure has complications, and that is important to discuss as well. In the real-world experience, the hospitalizations for heart failure have gone down significantly, about 73% reduction after MitraClip. So if you have a MitraClip, 73% reduction in your chance of being rehospitalized for heart failure after the procedure, which is pretty important in terms of quality of life. So I'm going to wrap up in a minute and just tell you that this patient was presented in our heart team, and our heart team is composed of a imaging expert who does the ultrasound portion, an interventional cardiologist who performs the procedure, a surgeon who's evaluated the patient for surgery, and an anesthesiologist. And every case is discussed in a heart team approach. We present all cases, and really I think this is one of the this is sort of the future of heart disease. It really requires a team, and as a team we can pretty much treat anything and everybody, and that's wonderful. So this was a picture of her procedure. Again, this is a sample of a procedure, but you can see that the regurgitation before on the right, all that sort of flow backwards into the left atrium, and here you can see this little T here, and that's the device, as I was showing you on the cartoon. That's us bringing the device into the ventricle, and we can leave patients with very, very little regurgitation. At the very end, you'll see here the final picture. There's very little regurgitation left. All that sort of colorful, bright red flow that you saw earlier is essentially gone, and that's why. And so she had a successful procedure. This is what they look like, the clips, if you were to take an x-ray of them. So you can see here we put in more than one clip. Patient had 2 clips, and they're very secure. They can sit right alongside each other. Patient ended up doing very well. She recovered fully her kidney function. She was left with only mild regurgitation, and she was discharged only 3 days after her surgery, and she came in quite sick and left looking really, really good. She's back to her baseline, and she's had no recurrent hospitalizations over the past year for her heart, so she's doing quite well. So in summary, Mitral regurgitation is the most common cause of valve disease. It actually, its prognosis is poor if you're symptomatic. It's very important that if you have symptoms that you see a doctor and get evaluated. Surgical repair or replacement is still the standard of care, and we have a center of excellence here at UCLA, a mitral valve surgical center of excellence here for patients that have mitral valve disease. If you have mitral valve disease and your surgeon or our surgeon feels that the surgical risk is high, one of the wonderful things is that we can offer MitraClip, and this device really leads the way as the first and only FDA-approved device for the treatment of mitral valve regurgitation. And it's been shown to be both a safe and effective way of treating mitral valve, and it leads to improvement in your quality of life. Our team here at UCLA is composed of Dr. Ravi Dave, who is our Director of Interventional Cardiology, as well as Dr. Shiv Kumar, Director of all of Interventional Cardiology here at Reagan as well, and Dr. Richard Sheeman, who's Director of Cardiac Surgery. In terms of the other team members, myself included, Dr. Press, Dr. Oljay Aksoy, who was originally supposed to be here but couldn't make the talk today, but he's a member of this team, as well as Dr. Nasser. And then we have, again, our surgeons, Dr. Sheeman and Dr. Payman Ben-Harash, who's also one of our surgical experts in mitral valve disease, and cardiac anesthesiologist, Dr. Ho. And we have an incredible group of echocardiographers who really show us the way. Dr. Vorobiev and Dr. Yang, specifically here at Reagan, have the most experience with this procedure, and we work with them very closely for each procedure. And we have two wonderful nurse practitioners, Dr. Jean Hushting and Partnip Chertum Wang, who are happy to help coordinate any appointments or questions that you may have should you want to come to our center. If you do have questions about mitral valve disease, or you have a diagnosis of mitral valve disease and want to come get an opinion here at UCLA, please feel free to give us a call. We're at 100 Medical Plaza, 310-825-9011. And again, myself, Dr. Press, Dr. Aksay, or Dr. Nasser would be happy to help you. And thank you so much for joining me at this webinar. I had a great time, and I'm looking forward to answering any questions that you may have. So we have a couple of questions. So, how do I know if I have mitral valve disease? So, one of the most common symptoms is shortness of breath. However, people who have mitral valve disease may not be symptomatic, and this may be diagnosed on routine physical by your primary care doctor, for example, by listening to your heart. If you have a murmur that's loud, then your doctor will usually order an ultrasound or an echocardiogram, and the echocardiogram is truly the gold standard for diagnosing mitral valve disease, and so that's how you know if you have it. The second question is, what are the symptoms of mitral valve disease? And I talked about that earlier. Shortness of breath is one of the main symptoms, and heart failure are the same symptoms of mitral valve disease. What are the risks and benefits of having a MitraClip procedure? So the risks we went through, it's generally less than about 8% risk of complication. Major complications, probably less than that, about 2 to 3%. The benefits of the procedure are that it's not invasive, meaning that it doesn't require open heart surgery. It has a very high 93% success rate, and there's about a 75% chance that you're going to feel better and avoid coming back to the hospital if you have heart failure and have a MitraClip. So those are the benefits of having a MitraClip procedure. And what should I do if I've been told that I have mitral regurgitation? I think it's important that you see a specialist who, either a cardiologist or a specialist in cardiology who deals with valve disease, to really look at the valve and to take a good history and screen for symptoms and decide in combination with you if and when you should ever need any surgical repair or MitraClip procedure. Thank you very much.